Hello friends, today we are going to discuss about the massive transfusion protocol. This was the question which were asked in DRNB critical care exam June 2022. So massive transfusion refers to the transfusion of large volume of the blood products over a short period of time to patient who has severe or uncontrolled hemorrhage. So massive transfusion protocol describes the empirical treatment that optimizes the management of resuscitation and correction of coagulopathy arising from severe hemorrhage. In adults, several definitions of massive transfusion exist based on the volume of blood product transfused and also the time frame over which this transfusion occurs. So, three most common definitions of massive transfusion in adult patients are transfusion of more than or equal to 10 RBC unit, which approximate total blood volume of average adult patient within 24 hours. Then transfusion of 4 RBC units in 1 hour with anticipation of continued need for the blood product support and replacement of 50% of total blood volume by blood product within the 3 hours. So the majority of the current understanding regarding the homeostasis and pathophysiological changes that occur during massive hemorrhage and the resultant massive transfusion are derived from the animal and adult trauma patient studies. The hemostatic defects in anema patients undergoing massive hemorrhage are dynamic and have multifactorial pathogenesis that relate to the early trauma-induced coagulopathy, transfusion of blood products, and infusion of crystalloids. Early trauma-induced coagulopathy is associated with systemic anticoagulation and hyperfibrinolysis. Tissue injury from trauma or surgery releases tissue factor locally and subsequently systematically, which activates coagulation pathway. This results in massive consumption of coagulopathy, leading to consumptive disseminated intravascular coagulation-like syndrome, which is most commonly seen in patients with severe head injury or extensive muscle damage. Furthermore, hypoperfusion from massive hemorrhage leads to the thrombomodulin expression on endothelial cells. So thrombin thrombomodulin complex further activates protein C, which further limits the coagulation by inhibiting activated factor 5 and 8 and enhancing fibrinolysis by depleting plasminogen activator inhibitor 1 and accelerating plasmin formation. So the diversion of thrombin from cleaving fibrinogen to binding to thrombomodulin also reduces the activation of thrombin activable fibrinolysis inhibitor, which further leads to hyperfibrinolysis. The end result of this complex mechanism is characterized by early coagulopathy due to systemic anticoagulation and hyperfibrinosis. In obstetric hemorrhage, hyperfibrinolysis is the prominent sign both due to above mechanism and to uterine atony and placental abruption and acceleration. In addition to early trauma-induced coagulopathy and hyperfibrinolysis, further coagulopathy results from infusion of crystalloid blood product and severe anemia. So massive hemorrhage leads to the anemia, which reduces primary hemostasis by impairing platelet adhesion and aggression. So administration of RBC unit without adding clotting factors or platelet during massive transfusion results in further impairment of homeostasis from both hemodilution and metabolic derangement. So metabolic derangement like acidosis, hypocalcemia from citrate, and hypothermia because of the refrigerated blood products. So acidosis and hypocalcemia are the detrimental to normal homeostasis. Furthermore, hypothermia is associated with impairment of both platelet and coagulation factor activity. All of these exogenous factors contribute to vicious cycle of progressive coagulopathy due to lethal triad of refractory coagulopathy, progressive hypothermia, and persistent metabolic acidosis. So, pathogenesis of hemostatic abnormality in massive transfusion. So, which consists of dilutional coagulopathy, activation of inflammatory mediators, hyperfibrinolysis, thrombocytopathy, and metabolic abnormalities like hypothermia, hypocalcemia, and acidosis, which all contribute to pathogenesis of hemostasis abnormality in massive hemorrhage. So, how to predict this? How to predict the need of the massive transfusion? In trauma-associated severe hemorrhage, that is TASH score, incorporated 7 clinical and lab variables like hemoglobin, base excess, systolic arterial pressure, heart rate, presence of free intra-abdominal fluid, and complex fracture and gender. Then further, this score was further modified into simpler form, like presence of penetrating trauma, systolic blood pressure less than 90, heart rate more than 120, positive focus abdominal sonography for trauma appears to be as good as other complex scoring system to predict this massive transfusion. If any of the above four parameters are positive, then the patient is likely going to require massive transfusion. Now, the clinical management in the massive transfusion. In patients requiring massive transfusion, it is critical to maintain adequate blood flow and arterial pressure to maintain tissue oxygenation to the vital organ. In past, patients who are bleeding profusely, especially trauma patients, were initially given colloids and crystalloid fluid. So blood products were administered after 2 liters of the fluid resuscitation, usually guided by lab results to keep hemoglobin of 10, platelet of 50,000 and INR of less than 1.5. But what they have observed is even after doing this appropriate resuscitation, there was delay in there was a dilutional coagulopathy and blood loss was continued. So, mathematical consideration of the resuscitation studies highlighting the increased morbidity and mortality with crystalloid use. So, recent military experience and better understanding of pathophysiology of early transfusion induced coagulopathy has led to the early use of RBC, plasma, platelet, and reduced crystalloid use in resuscitation. So currently what we are practicing is we are administering RBC, plasma and platelet in 1:1:1 ratio. So this 645 ml product has the hematocrit of 29%, coagulation factor activity of 69%, 65% and platelet count of 90,000. So in addition, if storage defects are taken into account, this mixed product would have hematocrit of 26%, coagulation factor activity of 40 to 50%, and platelet count of 90. Furthermore, any attempt to increase concentration of one component will lead to the dilution of other. So the administration of RBC plasma platelet at 1:1:1 ratio was first proposed by US military and subsequently supported by military and then civilian studies. So the rationale for this 1:1 ratio is that it more closely resembles whole blood, which would help to treat and prevent early trauma-induced coagulopathy. The retrospective review of the patient receiving massive transfusion at US Combat Hospital demonstrated reduced mortality from 66% to 19% when RBC into plasma ratio decreased from 8:1 to 2:1. So, in studies, they have demonstrated that high plasma and platelet to RBC ratio improved survival in military traumatically injured patients with massive transfusion. So in June 2011, Canadian National Advisory Committee on Blood and Blood Product determined that retrospective evidence available at the time was insufficient to recommended RBC plasma platelet transfusion ratio of 1:1:1 as standard of care for massive transfusion in the Canada. Recently, prospective observational multi-centered major trauma transfusion study, that is PROMIT study, examine the association between mortality rate in trauma patient and transfusion ratios. So this cohort study demonstrated improved in hospital mortality with RBC and plasma and RBC and platelet ratio in 2:1 in first 6 hours. Then follow pragmatic randomized optimal platelet and plasma ratio, that is proper trial, is randomized trial to evaluate ratios massive transfusion, uh, massive transfusion patient to receive either 1:1:1 or 2:1:1 ratio of RBC plasma platelet with primary outcome of survival and also complication and length of hospital stay. The result of this study should further elucidate the optimum ratio of blood product administration during massive transfusion. So, massive transfusion protocol should have the following components. When and who should initiate massive transfusion? Notification of transfusion service and lab regarding start and stop of massive transfusion protocol. Lab testing algorithm like prothrombin time, activated partial thromboplastin time, fibrinogen level, blood gas, and thromboelastography if available. Blood product preparation and delivery. Other patient care needs such as blood warmer and nursing care. So MTP vary in their predetermined transfusion packages, but all include platelet and plasma unit with RBC unit. Furthermore, patient with obstetrical hemorrhage should also be monitored closely for fibrinogen level because it has been shown that women with the fibrinogen level of more than 400 did not develop postpartum hemorrhage. Similarly, data from the neurology and cardiac surgery showed that there is increasing bleeding tendency if fibrinogen level is between 150 to 200 mg. So, moreover, retrospective review from USA, May Hospital, USA hospital demonstrated that uh, increased ratio of fibrinogen to RBC is associated with improved survival to hospital discharge by decreasing death from the bleeding. So, monitoring fibrinogen level and early transfusion of fibrinogen concentrate or cryoprecipitate could be potentially beneficial. In recent military experience in Iraq and Afghanistan, whole blood transfusion compared with RBC plasma and apheresis platelet use reduced pulmonary uh, 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 and platelet use. What they have found is there was reduced pulmonary and tissue edema, which decreased the ventilation time and also allowed the closure of the abdomen with minimum delays. So, furthermore, retrospective analysis suggested that patients who received both fresh and whole blood and component therapy had better clinical outcome compared with those who received only component therapy. However, concern for transfusion transmitted infection and transfusion associated graft versus host disease remains. So, these are the different protocols of giving massive transfusion. So, we can administer in the form of 10 RBC, 4 plasma, and 2 STP. Then we can also administer in the form of 6 point RBC and 6 plasma unit. And then and then the third protocol is 5 RBC and 2. Then 10 RBC, 6 plasma, 2 STP, or 6 RBC, 4 plasma unit, and 1 STP. Then alternative medication included in massive transfusion protocol is recombinant activated factor 7, which is approved by US Food and Drug Administration to treat bleeding patient in congenital factor 7 deficiency and in patient with hemophilia A and B who have inhibitors against factor 8 and 9 respectively. It has been off-label in many settings involving massive transfusion. In several clinical trials in patients with trauma and undergoing surgery, recombinant factor 7A has not been shown to improve clinical outcome. Furthermore, recombinant factor 7A has been associated with thrombotic risk. The risk and benefit of using recombinant factor 7A in patients with massive transfusion is unclear currently. So few experts suggest that the factor 7A should be removed as an adjunctive therapy from institutional MT. If physician would like to use recombinant factor 7A as an adjunctive therapy, it should be given as early as possible at a time when hemostasis has not been severely compromised. Then the next component that we can transfer is prothrombin complex concentrate, which has been used to treat congenital coagulation disorder and for warfarin reversal in patients with active bleeding and undergoing urgent procedure. So prothrombin complex concentrate contains the factors like factor 2, factor 7, factor 9, and factor 10. Protein C and S with variations in the amount of factor between different products. Now, it is important to know the PCC product is available at institution. So, PCC can be three factors such as profiling, and it can be four factors such as K-center. Today, there has not been any prospective randomized controlled trial to evaluate the efficacy and safety of PCC in massive bleeding patients. So, in addition, prothrombin complex concentrate might be associated with thromboembolic risk as shown in animal studies. Hence, it is advisable to discuss the risk and benefit of using PCC as an adjunctive therapy in any institutional MTP, and it is recommended that PCC usage should be continually evaluated. Fibrinogen concentrate has been shown to reduce perioperative bleeding and transfusion requirements. Fibrinogen concentrate in conjugation with the PCC also have shown in few prospective studies to decrease the transfusion requirements and mortality in trauma patients. In USA, fibrinogen concentrate is approved for the treatment of patients with congenital fibrinogen deficiency, and it has not been approved to be used in adjunctive therapy in patients requiring massive transfusion. Therefore, it is recommended to discuss the risk and benefit of using fibrinogen concentrate as a part of MTP in any institution. Antifibrinolytic agents like tranexamic acid were demonstrated to reduce mortality in trauma patients in both civilian and military settings, especially if given early in resuscitation process, that is 3 hours from injury to the treatment, preferably within 1 hour from injury. In military setting, the MATTER study demonstrated that although patients receiving tranexamic acid were more severely injured, mortality in tranexamic acid group was lower than the group not receiving tranexamic acid. Moreover, tranexamic acid was shown to be cost-effective therapy in all low, middle, and high-income countries using data from randomized controlled crash-through trial done in civilian population. It has been suggested that tranexamic acid reduces the blood loss at the time of cesarean section and risk of progression to severe postpartum hemorrhage. So, the randomized control trial is currently ongoing to assess the effect of tranexamic acid in treating postpartum hemorrhage. Smaller studies also showed that tranexamic acid reduced the blood loss in pediatric patients undergoing cardiac and scoliosis surgery. Therefore, it is recommended that tranexamic acid should be the part of early resuscitation process. Now, lab monitoring during MTP. MTP requires adequate lab support to oxygen carrying capacity, hemostasis, and metabolic status in order to address and correct abnormality. In addition, lab results can be used retrospectively to assess the need for MTP adjustment. For example, if all patients have low fibrinogen value upon intensive care unit admission, increased cryoprecipitate and fibrinogen concentrate use is indicated during MT. The metabolic panel should be used to monitor metabolic abnormality during massive transfusion such as hyperkalemia and hypocalcemia. Point of care ABG measurement is useful in monitoring oxygenation. Monitoring hemostasis in patients with massive transfusion is challenging because there is no validated coagulation assay that can detect accurately the coagulopathies in massively bleeding patients in timely manner. So conventional coagulation assays like PT, APTT, and fibrinogen level are likely not available in real-time fashion. In addition, these tests do not detect some homeostatic abnormality, such as platelet dysfunction, hyperfibrinolysis, and factor 8 deficiency. So they also do not quantify the relative contribution of procoagulant and anticoagulant factors. So recently, it has been suggested that the point of care hemostasis assay, such as TAKE and the routine, might be better at assessing coagulopathy in patients requiring massive transfusion. This assay offers the clinician graphic presentation of coagulation process. So in addition, the parameters obtained from TAKE and routine could provide a quantitative measure of individual component of homeostatic process in adult patients. Hence, the use of take and rotem can provide information to guide blood component therapy in more timely manner. There are several advantages of using take and rotem. First, the turnaround time for these assays is shorter compared with conventional assays. Thus, they can be used in combination with clinical assessment for decision-making process. Secondly, these assays can detect hyperfibrinolysis, an important component of hemostatic abnormalities in patients with massive transfusion that cannot be detected by only prothrombin and activated partial thromboplastin time assay. Thirdly, unlike prothrombin time and activated partial thromboplastin time that can only test secondary hemostasis, whole blood assay assess all phases of coagulation, such as contribution of platelet to primary homeostasis and factor VIII to cross-linking the fibrin clot. Fourthly, take and rotem can be performed at patient's true temperature, which makes it more sensitive for detection of coagulopathy due to hypothermia. So, take and rotem has been shown to reduce the transfusion requirement and need for massive transfusion in patients undergoing cardiovascular and liver transplantation surgery. Nevertheless, the Cochrane review suggested that there is no evidence that take and rotem reduce the morbidity and mortality in massive transfusion patients. There is no universal agreement on the use of take and rotem to monitor and direct component therapy in patients with massive transfusion. So these are the complication of MTP. Like first is allergic reaction, then second is hemolytic transfusion, third is febrile non-hemolytic transfusion. Then immunological reaction like transfusion-related acute lung injury, transfusion-related immunomodulation, transfusion-associated graft versus host disease, and post-transfusion purpose. Then metabolic complications like hypocalcemia, hypomagnesemia, hyperkalemia, hypokalemia, metabolic alkalosis, acidosis, and hypothermia. Other adverse effects are hemostatic defect, infection, transfusion-associated circulatory overload, and ARM. Thank you, guys.